think we have some very positive news to share today, and we have some painful news that's already been out. So before we get into the Q&A, which we're eager to do, I'm going to start out with just some overview for you guys on the screen that will provide important context that, although I talk about it very, very frequently, I don't think that I haven't been able to get this across in a way that our communities, really can appreciate sort of what the circumstances are in healthcare in rural America right now. So this is looking at a mission health perspective. And when I say mission health, I want to be sure that people don't think about mission hospital. I know sometimes our communities aggregate their feelings in terms of individual hospitals, which is understandable. But I'm really accountable, and we're accountable for all of Western North Carolina. We have the only safety net hospital in Mission Hospital, which is the hospital for all of Western North Carolina. And then we have a number of very important community facilities that are critical in terms of how we can make services available and keep our communities strong and safe. And we live in a world, unfortunately, where healthcare is not being supported the way that it needs to be, and no more tragically so than within rural America. More than 100 hospitals have closed in rural America in the recent past, 3 in North Carolina. Less than half of all rural counties have labor and delivery services, as an example. And one of the thoughts was that the Affordable Care Act was going to provide significant benefit to rural America and other parts of America. And in fact, from a design standpoint, the way it was designed would have done that. The combination of providing subsidies, big subsidies for people who couldn't afford insurance, and the expansion of Medicaid for a safety net system like Mission, as you can see on that screen, we should have been about $8 million better off after the Affordable Care Act than before the Affordable Care Act. And that was specifically because the design was driven towards those that bore the majority of the burden for the uninsured and charity care. But because states across the country, including North Carolina, chose not to expand Medicaid, and because during the last version of the government shutdown that we're also facing today, they implemented the 2% sequestration, which was that across-the-board cut. Instead of being 8 million ahead, we ended up being 34 million behind. So that creates an extraordinary pressure for Mission Health, and again, each and every one of our member hospitals. And if we were to roll forward what we do today and just let that play itself out over the next 9 years, Mission Health would increasingly lose money. And so you could see over the 9-year period, if we rolled forward today, Mission Health would have a cumulative $31 million loss based upon what we do today. Now you might ask yourself, that doesn't make any sense. Why would that be true? And it comes back to a dirty little secret of healthcare, which is that Medicare and Medicaid pay far below the cost of actually delivering care. And the way that health systems make up the difference is to shift price and cost onto commercial insurers. And in a normal market where it's about 50-50 between government and commercial insurers, everybody's happy. Well, not everybody, but in our market, because for Mission Health overall, we're about 75% Medicare, Medicaid, no pay. Angel Medical Center is 77% Medicare, Medicaid, no pay. And there just aren't people to shift the cost to. So because those governmental insurers mandate the price that they pay to us, and we have no influence of that whatsoever, and they do not take into account our costs of providing care for the most part, we can't really raise price. So overall, across all of our patients, across all of Mission Health last year, our average price increase was 1.4%. That generated under $21 million of new revenue, just rolling forward. But our input costs rise far faster than 1.4%, and I'm sure for each one of you in your homes, you know, between groceries and gasoline and other factors, there's never been a time where prices have only risen 1%. So that gets layered on top of additional cuts from Medicare and Medicaid, 6.4 million last year. We seek and desire to provide wage increases for our team members. That was $37 million across 14,000 employees last year. We have input prices for drugs and medical devices and supplies that go up dramatically. Drugs in double digits, supplies in mid-single digits. When it's all said and done, when we start the very first day of the new year, compared to last year, we have to cut $37 million just to stay even. Then we look at what's going on in Washington, and to a lesser extent in Raleigh. And in every possible reform scenario that's been discussed, those impacts range from really bad to tragic. On top of our base case, they add an additional series of losses that we're just waiting to be voted on, perhaps as early as this week. It's not surprising because of the same demographic challenges that we have, and demographics are at the root of all of the challenges that we have, that Asheville was ranked as the 10th most Trump care impacted city. That would also apply to our outlying communities, even in greater proportions, but they don't do the analysis on the outlying communities. Why? There's many reasons, and we don't have time for all of those, and I want to get to your questions in just a moment. But the major reason is because of the change from income-based subsidies to flat tax credits. Now, what does that mean? Under the Affordable Care Act, for all of its good, bad, and in between, and it has all of the above, the government pegged the price of a silver plan on the exchanges. There's bronze, silver, and gold. It had mandated benefits, which included, for example, maternity care and pediatric care. And then it said, whatever the price of that silver plan is, we're going to look at your income and we're going to make up the difference between what you could afford and what the price of that plan is. So no matter how high the price of that plan got, the individual was spared that pain because the subsidy just rose. Now that we're changing to flat amounts, you can see on that slide some of the tragic impacts. So let's start with the family of four at the top. A family of four making $40,000, given the cost of a silver plan, would have received $23,200 in subsidy. Under the revised plan, they're going to get $10,000 because the tax credits are just a function of age. So they get $4,000 for the parent, $4,000 for the parent, and then $1,000 for each of the kids. Or actually, it's not quite that, but just think about it that way. They lose $13,200 worth of their subsidy. But that's nothing compared to the impact on the elderly. And that's why in many media reports, for those that have actually studied and understand, and it's so hard to understand, that this has been called, the Anti-Elderly Act. Because look at that example. A couple of two 60-year-old individuals with an annual income of $25,000 they would have received $32,230 under the Affordable Care Act. Why? Because that silver plan for elderly folks is expensive. And you have to make up the difference. Under the plan that's being debated, they would get $8,000, losing $24,000 of their prior subsidy. So if you make $25,000 gross, and now you have to come up with an additional $24,000 out of pocket, you think that's going to happen? It is not going to happen. So when we look at the additional pending impact on Mission Health and on Angel, which is a valued and very important part of Mission Health, the majority of the negative impact is because people across this region are going to lose their subsidies like there's no tomorrow. We don't actually have that much trauma coming from Medicaid. Why? Because we never got any benefit from Medicaid because the state never expanded Medicaid. Add those things together, and that frames a $412 million loss across the 9-year period as we look out from Mission Health. Now you might say, well, that's because, Mission is so inefficient. They're a bureaucracy. They can't operate. They're not skilled. They spend too much money on buildings, or they, have profligate spending. The reality is just the opposite. In part because if we weren't better than most everybody else already, we'd be bankrupt for the same reasons that our demographics are challenging us so significantly. This shows that on Medicare, we have, on an apples-to-apples basis, this doesn't actually include all of everybody's costs, but it's the way that you can compare yourself to others. We lose 2.5% on every Medicare patient. The average for nonprofit health systems is about 8%. So we're 3 to 4 times more effective than the average not-for-profit health system. Said another way, and this may astound you, but it's the world that we live in. Mission Health earned $61 million in net income. Now first, why do we even need net income? We're a not-for-profit. We don't have shareholders that we need to pay dividends to. We're not looking to drive up our stock price. In fact, we really look to provide the most possible care we can without going out of business. That's the mission that we have because we exist solely for the benefit of our communities. But we have to have money left over, or we can't replace hospitals when they're no longer able to function. We can't cover the cost of money-losing programs. There's so many things we can't do if we don't have income. So what is this slide showing? This is making the point about how unfortunate our demographics are relative to the way that our national health system is structured. It says that we made $61 million recently. And if we were able to pick ourselves up and move us to Charlotte or Raleigh or many normal areas across the nation, doing exactly what we do today, but just having those demographics and not changing a single other thing, we would have made $173 million. Now, if we had made $173 million, we could do all kinds of things. But we don't, we can't, it's not fair, but there's nothing we can do about it. We can't cry in our milk about it. We actually have to go out and be better than everybody else to keep our health system vibrant. Now, importantly, we do that in a way that is not only more efficient than almost all other health systems, but that is undeniably and unprecedented in terms of our outcome performance. Mission Health, which includes all of our members, Angel among them, is has been named one of the top 15 health systems in the United States using objective data, IBM Watson analysis, for 5 out of the last 6 years. That has never been done by any health system ever before. The death rate of patients in our hospitals is dramatically lower than state and national averages. More than 600 people go home to their families who would die in the average hospital if they were not in Mission Health System every year. 600 deaths. We have the same outperformance on readmissions and almost every other clinical parameter that anyone has ever measured. And that brings us back to our circumstances today. One final comment, and then I'll turn it over to questions. We've been involved at Angel Medical Center for some significant period of time. Prior to having a management agreement, we loaned Angel money without any other relationship because it was going bankrupt and was at risk of closing. Angel collectively has lost $1.4 million over the cumulative period between 2008 and 2017. It had a peak loss of $4 million per year just prior to our assuming the management agreement. We dramatically slowed the losses at Angel Medical Center and made up for many of the losses that had occurred over that prior time. But even this year, Angel is $3.4 million behind forecast. Not because it's bad, not because Karen's not a great leader, but because of the vagaries of rural healthcare as we sit here today. And so the good news that we have to share, and I think it's very, very good news, is that last night the Mission Health Board approved a $45 million investment in Angel Medical Center. We anticipate that to be a $43 million building, as well as additional costs that will undoubtedly be incurred. We used a decision-making process that focuses on the community's most important needs, and we painfully chose, with not one of us ever wanting to have to make that decision, knowing that it does create disruption and challenge and a burden and less than ideal circumstances for members of our community, that we did need to close labor and delivery services, including labor and delivery in that new facility would add an incremental $6 to $7 million just for the facility. But that's not actually the biggest problem. The largest problem is that labor and delivery, and we can answer other questions about that, loses between $1 and $2 million per year. And we, as management, Karen's recommendation, our support, the Angel Board supporting management's decision, said we can't let one program, even important, put all of the care at risk for a rural community. We just can't do it. Who among us hasn't at some point, for our family, for loved ones, had to make a decision between two bad alternatives, and you have to choose the least bad and the most effective for that community? Across America, rural communities are losing their hospitals. We are making a $45 million long-term, unprecedented in the history of that region, investment. We'll take your questions.
Okay. As early as June of last year, missions plan for Angel Medical Center was actually to expand the women's unit to keep up with labor and delivery demands and invest $4 million in a completely new women's unit just to meet the demands in the region. So in less than a year's time, what has changed to go from where you no longer need to even expand that unit, but just eliminate it completely?
So what we had the opportunity to do is to really look at the facility at large. And Angel Medical Center has a lot of opportunities from a facility perspective. It's an aging building. It would cost us millions of dollars to continue to even provide care in that building. And through that analysis, we looked at the 10-year market. We saw that what the growth patterns were. And then as we got closer and closer to a decision, we looked at all the service lines. And so as part of what Dr. Paulus said, we have to be good stewards of our resources. And when we looked at those service lines, the women's service line had the highest cost, and we were losing the most money based on that, providing that care. And so as we moved forward, we realized that continuing that service would put the hospital at risk. So it's really about sustainability for all residents of Macon County, and believe me, it's a tough decision.
And let me add to that, because I want to make sure, because you're raising a very legitimate question of, geez, how could they be doing this and then move to that? There were several other factors that were very important in that decision. One was that there had been some significant shift in where women were delivering babies from Harris to Angel for that recent period of time. And I had some concern that it was possible that Harris might choose to no longer deliver babies. And there has to be a delivery option available in that region. There has to be. As Karen noted, as we began to look at our expansion plans, two specific things happened. One was, as we were beginning the architectural and physical structural review of the building for that expansion, we discovered very, very significant deficiencies of which we had been previously unaware. We knew there were challenges, but we were unaware of the magnitude of the challenges. In fact, the challenges are so overwhelming that if we were to renovate and repair the existing facility, it would cost more than $50 million, more than the $43 million brand new facility. And then second, after that, back to the concern that we had about ensuring the community has access to viable delivery services, Harris announced their $6 million investment in labor delivery. So no longer did we have to consider, on behalf of our stewardship in the community, that there would be no labor and delivery services available.
You think the demographics for labor and delivery in Macon County still continues to grow? So that hasn't changed. That wasn't part of the factor.
No, it was never growing. It was not growing then, and it was not growing.
But in June, that's when you said that you were doing the $4 million investment. It was to keep up with the growing demographic trends of labor and delivery in Macon County specifically. So has that changed?
No, if that was stated, and I don't recall that being stated, that was not true. What we were keeping up with was the incremental demand at Angel Medical Center, which related to a shift in women from other parts of the Tri-County area. It may have been a misspeaking, but demographically, and your county manager has left, but I think we can all know, and you can all look, there is no increase in demand for labor and delivery. There has been no increase in demand for labor and delivery. There is no population increase. And the demographics are the same as all of Western North Carolina, which is we're aging in place. The over 85 subsegment is the fastest growing segment of the population. And the services that are being increasingly demanded are services that relate to chronic illness and aging, which includes gynecologic services, but does not include obstetric services.
A little late coming in here, maybe you already addressed this, but at the beginning you were talking about how this hospital has a higher Medicaid percentage of people who use that.
Medicare, Medicaid, and no pay.
Right. Had the state of North Carolina expanded Medicaid under the ACA, would this have been prohibited?
I don't know if I can answer that. We would certainly be a lot better off, and we would have had a different set of information to look at. It's possible that it could have narrowed the loss enough. We don't expect places like Angel Medical Center to generate an income. We didn't get involved to make money. We don't believe there's any hope of making money at Angel Medical Center. We need to get all of our entities to a sustainable break even. And then across the other aspects of the system, we have to generate enough capital return so that when a facility that is essentially dead and needs $52 million in renovation and replacement, that we have the money to put $45 million into that community, far more than has ever been invested by any other entity in the history of time, to ensure that care remains available to that community.
How old is the facility, Angel?
It was built in different stages. So the oldest building that we currently use was built in 1956.
And to give a sense of just how challenged that facility is, there's actually, a floor 6 3/4 or 2 1/4?
2 3/4, yes.
Because the building is
Yes. Yeah. It's been added on to a lot.
And how many babies are delivered a year there?
It's just right under 400.
and that's
And
a recent phenomenon. The average has been around 260.
Mr. Greb?
Do you know what a percentage
If you call market share shifts growth, that's true.
Oh,
Yeah.
the media packet that was handed out for the women's expansion specifically states from Mission that the expansion of Angel Medical Center's women unit will accommodate the growing number of births in our region. So that's not, so there's an increase.
So what happened, and if you look at the demographics, there's a shift from other counties into,
It doesn't say Macon County, it says the region.
yes,
Yeah, so-
there's a shift from other counties into Angel Medical Center. That is what really caused the increase in the number of births.
Yeah, we could debate if you'd like, and I'll just stipulate to your assertion that the region was an unclear word, but I don't think any of us can debate the numbers because they're just factually correct, and you can, unless anybody wants to go into alternative facts, but the numbers are the numbers. There's been no growth in that region from a birth standpoint, any material growth. Could there be 8 more, 8 less? But there was a market share shift to Angel Medical Center. That was growth, no question.
Dr. Paulus, can we talk a little bit about, we're live streaming this, I'm sure people are writing us questions, those who live in that area who may be expecting babies, let's just kind of regroup, those services will end this summer. So in the meantime, and moving forward, they'll go to Harris and Franklin, correct? Or they'll come to Asheville. Are those going to be the only 2 options for those in that region, or will there be anything looking 5-10 years from now that may be available to them?
Go ahead, Karen.
Well, I think, it's always a patient's choice where they seek to have their care. And we are doing a transition plan right now. Our intent is to take care of moms before they have their babies and after they have their babies and those children as well. And then to work collaboratively. So we've mentioned, a working relationship with Harris. And also, they have an option to go to Mission Hospital to deliver. And actually, there's a high percentage of our residents in Macon County that now travel to Asheville to have
You know
their
that number?
babies. We can get that for you.
It's around 25%. That's,
Yeah.
For
don't,
Macon, not Macon, because I know you said, when your press release, you said there was a quarter of
Yes.
Macon, Jackson, and Swain. I mean specifically Macon, it's still
Yes.
about out of order?
I think so. We could clarify that number because I don't want to misspeak with a regional word again.
And you know, I guess in healthcare, as volatile as it is, you can never say never. Our plan is to, when we build the new hospital, to have the option to expand at some point in time if the market changes and the demands of the market change. So I think we have to be really flexible as we move into the future.
Yeah, and I want to add a couple of things. One, I'm not blaming anybody because our policymakers in Raleigh and at the federal government, they also have untenable choices. They have a deficit that's rising at the federal level, perhaps dramatically so if the recent proposals go through. They have very, very difficult choices. But if we have collectively 77% of our patients in our region that are governmental or no pay, our dialogue needs to be about what is the health policy? How do Medicare and Medicaid pay? Because we don't choose our demographics, we have our demographics, we love our community members. There is nothing that any one of us can do to change what we get paid. We can change how efficient we are, and we work on it every single day. So ultimately, all of our citizens need to understand that all of this discussion about health reform is real. It's impacting real people every day. This is what we're being asked to do. Do more with less. Stop doing all the things that you are doing. We are not going to pay you for those things. And that's the world that we need to navigate on behalf of our communities.
On that note, sorry, go ahead. Okay. On that note, saying that we need to advocate on behalf of our community, and this who is leading the charge for healthcare in our country is the congressman that represents this area that this is affecting. Have you had this conversation with him?
We have had the conversation.
Do you think that he was aware something like this was going to happen in his district?
I think it would be impossible for him not to be aware of things like this because it's happening all over America. And I think he struggles with the difficult challenges. We have $20 trillion worth of debt at the national level. There have been significant challenges. The subsidies that I described, which are so helpful to that 60-year-old couple to get $32,000 in subsidy, it's also a completely blank checkbook. Whatever the price of the Silver Plan rises, the subsidy rises along with it. So our congressional representatives are not mean-spirited. They don't intend to harm anyone. They have unfathomable choices just like we have.
So what is the solution? I mean, you bring up some of these things, and the numbers you show that the plan that's under consideration right now would certainly cut a lot of the subsidies. So what is the solution to this problem? Because as you said, rural healthcare in general in the United States is facing all these problems of cost.
Well, we don't have the time today to go into the solution, although it's my passion in life. I've done nothing but this for more than 25 years. I think I have a unique perspective, as does Jill and Karen. In brief, if I had a magic wand, I would provide a basic preventative service and chronic disease plan for every American with a catastrophic wrapper on top of it. I would allow insurance companies to innovate and compete for the middle ground. And I would redirect through various means, including a dramatic expansion of the disproportionate share program, which may not mean anything to you, but it's a way that the federal government, it's been cut over and over again, but it's a way that the federal government redirected funds to providers that had more Medicare and Medicaid patients, recognizing this dilemma. And I would target my coverage to those things that we know from the evidence base that they work, and I would not cover things that the evidence shows don't work. Across all of healthcare, experts estimate about a third of the things that are done don't add any value. And we waste a lot of resources. And so, that's a dialogue for another day.
How likely is it that the moms will stick with Angel for their prenatal care if they can't deliver at the hospital?
I'll make one comment, and then Karen, I'd like, we have an example of this. So in Transylvania, we closed our labor and delivery about a year and a half or so ago. That was actually a different set of circumstances. That was less about the financial sustainability of the program and more about a best practice safety quality concern because of the very low volume of births that was originated by our own obstetricians who said, we're not sure that we should continue delivering babies here because of all the infrastructure that's required, and we don't want any mother delivering in a setting that's less than state of the art. After the closure of that labor and delivery service, the outpatient obstetrics, prenatal, postnatal, and GYN care has grown, and it's grown significantly. Because the women had already been choosing to find other alternatives, and the ability to have the overwhelming majority of your care close to home was a choice that they really appreciated. This is not the same situation.
Mm-hmm. But I do think, it's hard to tell. Again, patients have choices, but I think that being close to home to do that prenatal care will give them an option that they find both high quality and convenient. And then looking at, where they choose to deliver, then we can support them again after they have their baby. So I hope and anticipate that we'll maintain a lot of those patients. We continue to provide services both at Franklin and in Silva.
What will this mean for the health of babies and moms, especially high-risk pregnancies in the county?
Again, it goes back to the management of those patients, and we really want to provide high-quality care. Now when we have those patients, we manage them in collaboration with Mission Main Hospital, and a lot of those patients, if they're high risk, are then forwarded there for delivery. And so I don't anticipate any change in that process.
Yeah, I would add,
It's so critical to have access to great prenatal care, which they will have. We also have a working relationship with MAHEC. So when you look at who are the OBGYNs that are really specialized in taking care of high-risk individuals, this will allow us even a closer connection with them so that there's good collaboration with prenatal care with the high-risk specialist. If you're high risk, and I was a high risk mom, and when you're high risk, you need to be delivering in an area, in a program that has all of the safety net services available for you. So our high risk individuals would be working with the MAHEC clinicians as well as with their local, in a way that I think that will make a great handoff and assure they're getting the best care possible.
and I would just add to that the overwhelming majority, I won't say every, but the overwhelming majority of all high-risk births today are at Mission Hospital. And that's the only place that they should be, because we're the only facility that's equipped for truly high-risk births. I actually believe that this is likely to enhance care for high-risk births, because I think it will be less likely that Harris will choose those sort of upper end of the risk, because they'll have a lot more patients of normal risk delivering. We already have a neonatal intensive care relationship with Harris. You might say, geez, it's weird, these guys are competitors, and we are competitors. But we can't focus on competition to the exclusion of our community's benefit. And so we have an existing relationship with Harris on neonatal services. We have and will expand our neonatal teleservices, where we make our neonatologists available virtually at Harris and at Angel. We have, as another example, since Mission has been with Angel, we've dramatically upgraded the emergency department. From a clinical standpoint, all of those physicians are now board-certified emergency physicians, which was never true before, and most rural communities could never have. They receive extensive training in neonatal resuscitation, and they're supported by Mission Children's neonatology team, and we have an immediately deployable infant transport team from MAMA, our helicopter service, whether to Harris or to Angel, or frankly to any of the smaller community regional hospitals.
What's the status of the nurses and the midwives and the doctors that are providing labor and delivery at Angel now? Are they gonna get laid off or?
So we're working with the team of the inpatient unit staff, and actually we started working with them immediately. We have great support from Mission HR in looking at our Career Exploration Center. Also, we have a number of positions for those nurses that are open within Angel, and then up at Highlands, cashiers. So we've already had a number of them apply for those open positions. And if they choose to stay and not to apply for one positions within those two hospitals, then we will make sure that we have a severance package for them. But our hope is that they'll stay part of Mission Health, and we'll be able to have them keep being part of our team.
I would just add to that.
Yeah, in our rapidly changing environment, we see changes in programs across our system all of the time. We do a lot of cross-training. We have openings in a variety of areas. As you described, you have openings at Angel. Our Career Exploration Center actually helps folks look at what are the options locally, what kind of cross-training could we do to make sure that you're able to maintain in your community, or if you're interested in other opportunities, we look at those as well. So there's a lot of support that's happening every day that you may not know, not only in our rural communities, but here at Mission Hospital, it's happening every day.
How big approximately is that team of doctors and nurses?
Yeah, how many doctors did you have, did Mission have contracted to deliver at Angel Medical?
We had 4 physicians and 3 nurse midwives. And so in the inpatient units, right around 25 staff that are impacted. Now the clinic staff, because we're still, remember, going to be having prenatal, GYN, postnatal, all those women's services really aren't going to be as affected because we'll still have that service available. Will some of the shifting go around to some of the other practices that have openings? Possibly.
And I would just
around 25, just to clarify,
around 25. And I would just add, first on the 25 number, we also have 24 open positions at Angel currently, and we have another 18 open positions at Highlands. So we're obviously looking to transition those employees. Our historical success rate with the incredible Career Exploration Center that Jill was describing, we have about a 60% historical average of getting a job offer to a displaced individual. Not everybody takes the job offers, but that's our job offer rate. And with respect to the 4 obstetricians and 3 midwives, and I want to let you, make you aware that the infrastructure that supports delivery goes far beyond that. And it'll give some additional insight into the complexity and the cost of the program. So, for example, the other members of that care team include pediatricians who have to be available 24/7 by 365 for call coverage for deliveries. They have to be available even though we don't even average typically 1 birth a day, okay? Historically, the local community pediatricians provided that call coverage, and so that was something that they did, and there wasn't a cost to Angel or to Mission for that. Not too long ago, they chose to relinquish their hospital privileges and to no longer take call. And so we were forced to, and I understand, right, they have their own problems and their own demographic challenges. It's not a criticism. That induced a very large amount of spending, approaching $1 million a year, to pay premium care, call for physicians in Silva that had to be prepared to drive at a moment's notice. So again, that distance between Silva and Franklin, we had to do the inverse of that drive to make care accessible and safe. And the expansion of the 4 obstetricians and 3 midwives, again, comparing it to Transylvania, where we had 2 obstetricians and no midwives, right? So the magnitude of that cost infrastructure, and then those obstetricians and midwives had their own limitations on how much call they were willing to do, and right, so you have the macro environment that's cutting funds, you have no growth, you have rapidly escalating costs, and you have dramatic needs within the community, and we have to focus on helping the most people we can.
Why the July 14th date? Like, why was that? Because to me it seems kind of abrupt, at least from the announcement standpoint. It's something that you've been talking about for so long, and I understand, but I know that the county leaders in Macon County were completely blindsided and caught off guard until they were called on Tuesday morning. And so I know that it's not something that they planned for, it's not something that our county departments have budgeted for in terms of EMS and the health department, who plan to see an impact from the change. And they're in the middle of budget season, so they're trying to finalize what they're doing, and the date, it was an arbitrary number. Is it what you think a transition needs to be? Was there thought put into that?
There was considerable thought put into a date, and so you have 2 options when you change a program or a component of it. One is to kind of let that transition naturally, and one is to set a date. And we chose to choose that date because once you announce, as we're announcing, getting to build a new facility, and that we don't plan to include labor and delivery in that new facility, then both our staff that work in that unit and our physicians know that there's a time limit to when they're going to be providing that kind of care, and they start looking for other positions. We wanted to set a date so that we could have a planned transition, and then make sure that we could retain the staff, work with them, and then give a transition too for those moms that are expecting babies after that date.
So said another way, and it gets to the issue of, well, why didn't we talk to all the people ahead of time? It's the same reason, because of the understandable, right? Because of the understandable emotion and pain and challenge associated with this. The moment that there's even a single mention of the possibility, everything begins to unravel, and you place at risk mothers and babies who could be impacted without any kind of transition, and we can't let that happen. And to the extent that some may say, they had no idea or things of that nature, for some it's true that they had no idea about this particular decision. But nobody who pays any attention to what's occurring in rural America and who focuses on the needs of their communities and the day-by-day closures, the relative rarity of having a labor and delivery program in a rural county to begin with, I don't think anybody could truly say that they couldn't imagine.
You mentioned, Dr. Paulus, earlier, as a healthcare system, you're being asked to basically do more with less now. So can we expect any other cuts beyond these services at Angel?
So first, having learned from past presidents, you never say never, because who knows what the world could be tomorrow, right? I don't know if I'm going to wake up with an incurable disease or, God forbid, some other tragedy occurs. we make program decisions every single day. We make program decisions at Mission Hospital, we make them at Angel Hospital, we make them at Transylvania, et cetera. But with respect to Angel in particular, we've done countless hours of analysis and forecasting. We've done sensitivity testing where you look at different things that could go wrong, and I realize some may think we're not very smart, but we think we're pretty good, and we think the evidence, the objective evidence by outside observers verifies that feeling. And we have made the decision to invest $45 million in that community, again, a level of investment that is unprecedented and never heard of before. And we don't do that because we're stupid. We do it because we care deeply about that community. We accept that people aren't going to see it that way all the time, and that's one of the challenges of being in our roles. That's what leadership is, doing the right thing, even when you're going to be disliked about it. And we are planning to keep all of the other services that currently exist at Angel Medical Center. All this talk about they're going to become a glorified emergency room and a doctor's office, that's not true. If we were focused on financial return, that is what we would do. That is exactly what has happened in many rural communities around America. But we are pushing the chips on the table and saying $45 million is going to go into that community to keep those services available. I would not do that as an investment, but I would do it as an investment in those people.
So without the 40, so you're saying without rebuilding the hospital, it essentially would, you'd have to close it because it's in such bad, do you have like a timeline for when, A, a timeline for how long you think the current facility would last in its current state, and B, your timeline for the investment?
I think
Before
we're,
you answer that, Dr. Paulus, we could have got 5 more minutes before we begin.
Okay, and we might go a little bit longer.
Perfect.
so I think for the new investment to build a new facility, you know, we have to go through extensive planning. And the reality is between 2 and 3 years that we could even think about having a new facility, because we want to make sure, you know, it's an important investment in the community. We want to do it right. And we want to make sure that we have members of our community participating and giving us feedback in that design, because it has to work for all of our residents. And as far as the current facility, I can tell you that daily we are having to fix things. And so we have a great team that take care of it, but it's a challenge, just like an old house would be. You know, the water heater breaks and the furnace goes out, and when it rains into our windows. And so you know, it is a daily challenge, and we're committed to keep that facility warm, safe, and dry for our patients and our staff.
Even with this $43 million investment, we're going to be investing $3 million in the next 2 to 3 years.
Just to keep it functioning.
Just to make sure that we're meeting the needs every day. It is an older facility. It has to be replaced. It's time. It does take several years to plan and to do this effectively, but we're on a clock from the perspective of that facility cannot be left without the kind of input, even the short-term investment, but really the most sustainable way to think about ensuring that care is there, and that we're not one of those statistics 5 years or 10 years from now that we see across the country. Making sure that we're one of the surviving communities that has sustainable health care. It's the $43 million investment and doing it effectively.
And I'd add one other thing to that, and we might be able to do it faster, particularly if we don't have opposition from other local healthcare organizations, Harris or others, and I have no reason to believe that we would, that Harris, although an excellent competitor and has been a good competitor colleague to work with. We've gone through a number of challenges together. I have great respect for their leader and what they're doing. if they don't become antagonistic just because they can, and again, I don't think they will, that will enable us to get through the CON process very rapidly and might enable us to shorten that timeline.
Is it gonna be in the same location?
That's not a final decision yet. It will be,
Close. You know, we do have land that's close to our current facility, but there, you know, we're continuing to have our options open. As you know, building in the mountains is a challenge, and so we have to make sure it's the right place and that we can easily, you know, core down and get the services into where we're gonna end up before we make any decision.
and we're doing this right now at McDowell Hospital. If you want to go online and look at the webcam, a brand new replacement facility, not too dissimilar, you know, from this. McDowell does have labor and delivery. One of the other sort of crazy nuances of our governmental healthcare system is if you're a critical access hospital, you do not have access to those disproportionate share funds that I mentioned that redirect payments to those that are bearing an extra burden of Medicare and Medicaid and no pay. McDowell, as not a critical access, does have access to those funds, and Harris, as not a critical access hospital, has access to those funds. But Angel does not, and there's not a thing we could do to get access to them.
The property that you said is near your current facility is substantially smaller than, it seems like there's it's like, what, 9 acres, 8 acres?
There's
in there?
9.
Yeah, so I'm just curious if you anticipate there being challenges fitting the services you have currently at your facility in the smaller campus, that sort of thing.
No, I think that 9 acres would meet our needs.
What's the current acreage in your medical?
You know, I'm not
So,
sure, is it 11? But yeah, but a lot of that is kind of rolling hills that we can't
And
really
it's not well
use.
designed.
No.
Remember, there's a floor 2 3/4.
When you design from scratch and you think about the future with all the changes that are happening in technology, you can design a much more efficient and effective space. Trying to retrofit buildings that were built 20 years, 30 years, 50 years ago to the kind of technology we have available today, we'll be able to do it much more effectively.
The patient rooms at Angel today are 40% below normal size standards. It's incredible.
There's never been a time, if you think about our healthcare environment right now, that has seen so much challenge, so much headwind, and changing so rapidly. I know we find it humbling every day. We're also deeply committed to making sure that we have health in healthcare systems in our communities, and we consider all of Western North Carolina as our healthcare community, making sure that we create sustainable ways that there will be the level of high quality, safe, effective care that supports you and your families going forward. So we're all in. It's humbling, it's difficult. We make challenging decisions. But we also are being successful in a very difficult time at making sure there's great access to high quality care.
Maybe 1 or 2 more questions if you have them.
Do you have any concerns about the access from Franklin to Mission in like winter months? Because there's so many times that Cowie and Boston are both covered in snow and they're almost impassable at times. To be in labor, high risk labor, and trying to make the hour and 15-minute commute in that type of weather. I know that's a question that we got a lot. I know it's maybe small in the grand scheme of things, but it matters.
It's
to
not
families.
small.
It matters to
Yeah.
people.
Sure, and I think that that's where.
You can't plow the roads, so.
Right, and that's where, you know, what Dr. Paulus talked about, our emergency room physicians are all board certified. We will still have OB providers in that community.
Are you guaranteed to, or once this change happens, but they don't want to stay?
Then if that's their choice, then we'll recruit, but that's our commitment. And so having that, we have basically all those services we would need within Angel Medical Center to care for those patients. And then we have the added benefit that when the weather allows, we can either fly or transport the mom and babe to a higher level of care if that's what they need.
And then you
at
said that
Mission.
you'll recruit, but I know that you've kind of inherited this because you're you're the newest addition to Angel Medical Center in terms of leadership, because it's changed over the past couple of years.
Uh-huh.
The current women's unit program and who's currently there, they were recruited. They were part of a greater vision at that time, and they moved their families there. And I'm in that community, so like I know them, and they uprooted and they trusted Mission to come there to recruit because there was a greater vision then. In the past few years, that changed. So if it comes to having to recruit again, I don't think you have as much selling, or buying. How you can convince them if they don't want to be there because they don't, but the services that they're offering are gonna be limited, and as understandably their clientele. You have one pediatrician that's on call 24/7 now, which is, like you said, part of the problems in sustaining that unit because of the lack of doctors that want to contract or work with Mission because of one reason or the other, which led to the decision to close it, like you said. So I guess there's not even a question there. I don't see how that's gonna, maybe a shiny new building would be
Let me make a couple.
beneficial.
Let me make a couple of comments, right? So first, back to the question of high-risk deliveries.
Right.
And not minimizing that in any
Right.
way, shape, or form, because that is a really important thing. But the reality is that that's no different than it is today, which is that the high-risk deliveries need to get to Mission, and whether you can plow the roads or not plow the roads has nothing to do with whether Angel's labor and delivery.
And I know the numbers might be, and speaking from personal experience, they should get to Mission, but my niece was a high-risk pregnancy. My sister was treated with Mayheck, and they delivered at Angel. That was the decision because that was where she went. And I feel like if just me personally being one person in a room of a dozen has a story like that, those numbers are doubled once you ask the Macon County community those same things. And she was from Silva and delivered at Angel because she was high risk. And so, she was from Jackson County that came over. And so it's not just the Macon County families that are going to be impacted, what I think are great and significant, but the neighboring counties that instead of making that drive to Asheville, which is substantial, it's a resource that they're all losing.
Yeah, so I would say two things, and again, every individual with any challenge is always very important. There are different levels of risk, and Harris will have the same capabilities, and in fact, if they are very likely to get a lot more deliveries through this, we'll have the ability to invest even in greater capacity. We discussed previously our relationship with them on the neonatal intensive care unit. So with respect to that local community, that resource will be available, and Mission Hospital will remain available.
I know I keep sidetracking from what I said originally, and while that relationship is great, and you said your decision was made based on their decision to invest in labor and delivery, but you made your decision to cancel it without even consulting them. So you're working on the assumption that they're just gonna be okay with it. Maybe you've talked to them since Tuesday, or since yesterday, since they held a press conference, but they didn't.
Without revealing all conversations, we did talk to them before Tuesday, and they had also made very significant public statements. And we were very confident that they were committed to their labor and delivery program, and we know that they also have access to those additional resources that we do not.
If a patient gets the prenatal at Angel and they like their doctor, their Mission doctor, can that doctor deliver their baby at Harris?
They have an open medical staff, and so they can apply and be part of their medical staff there. So that is an option.
Is that likely? Are doctors likely to want to do that?
I would say it is likely.
That's what most doctors do
Yeah,
every day.
They do. And also, the possibility too in our partnership with Mayheck is those physicians can choose to come up and deliver at Mission as well. And so, and that's really what happens from Transylvania is those physicians go to Mission and deliver. So, it really kind of opens up the possibilities when you think about it from that perspective.
One more if anybody has it. Okay, I'll just close with this comment. We are very sorry that we cannot keep this program open. We looked at every possibility that we could conceive of. We evaluated the possibility of not having inpatient labor and delivery, but having a birthing center. But that became inextricably linked to a need for a hospital within 15 minutes. We looked at reconfiguring the program as we've done many, many times, and we just couldn't find a way. If there were additional resources, and if the county or other municipalities said, you know what, we believe it's worth investing $7 million in a building and $1 to $2 million in operating loss subsidy, and the community and residents wanted to have a tax, or, you know, if you look out this building and you see the AB Tech towers over here, Asheville passed a sales tax to fund those buildings. So if the community really believes that that's something that would absolutely have to be there, we haven't completed the design of the new building. I don't think that's realistic, given the circumstances, but we are open to additional resources that we don't have access to that might alter that landscape. But at the end of the day, they don't have any more money than anybody else has, so I don't know how that's actually possible.
Thank you all.
Thank you.
Thank